All right. So we are just at 12 o'clock. Happy New Year, everyone, and welcome to our monthly psychology grand round meeting. We're very lucky to have Dr. Laurie Keefer with us today, who's going to be talking to us about brain-gut behavior therapies and the management of IBS. A little bit about Dr. Keefer. She is a health psychologist and professor of medicine, psychiatry at Icahn School of Medicine. She directs the Gaining Resilience Through Transitions program, an integrated multidisciplinary service supporting 12,000 patients at the Sinai IBD Center. Her clinical practice focuses on psychological aspects of medically complex IBD, and I think that's something that is so common and really inherent to everyone's practices. Her research focuses on the application of positive psychology principles to the management of chronic digestive conditions. She sustained NIH funding since 2008 and was PI of an NIDDK-funded T32 training grant on the intersection of GI physiology and psychology. Her expertise is the development of personalized, scalable GI self-management interventions. It led to her co-founding the Sinai spin-off company Trellis Health, which is a tech-enabled chronic condition management solution based on her GRIT method. Dr. Keefer is chair of the International Rome Foundation's Gastropsychology Organization. She has more than 250 peer-reviewed publications and is clearly a sought-after speaker, mentor, and collaborator within the national and international gastroenterology community. She received her PhD in clinical psychology from the University of Albany, New York. She completed her internship and fellowship in health psychology at Rush University Medical Center, and she was on faculty at Northwestern for 10 years before joining us at Sinai in 2016. We are very lucky to have her on staff also as a speaker here today. And Dr. Keefer, we all look forward to hearing what you have to say.
Thank you so much for the introduction, and it's nice to be presenting. Most of the time I end up presenting to gastroenterologists, so I'm very excited to actually be able to share my passion for psychogastroenterology with my fellow psychologists here. I just wanted to share briefly my disclosures. I'm assuming everyone can see my screen, okay? Okay. To begin here. I don't know why that's doing that. You can see my screen, right?
Yes, we can.
We see it.
Okay, sorry about that. Okay. So to first sort of start off, a little piece of history, psychiatry, I was actually at the Williamsburg Psychiatry Hospital, the first psychiatric hospital in the United States, a few years ago with my kids, and I was very excited to see in their display of different surgical tools that they used, the first enema syringe. And so I think this is very relevant to psychiatry, always having acknowledged the suffering of constipated patients, really, again, speaking to that brain-gut connection. So as Dr. Balmy has mentioned, psychogastroenterology is sort of is the field where we apply psychological science to GI health and illness. I did put up a little QR code if any of you are interested in joining the gastropsych community. There's probably about 50 of us in the United States practicing as clinical gastropsychologists, but our science is also a broader field that includes experimental psychology, behavioral intervention science, and cognitive neuroscience. And that's going to be important as I sort of explain the rationale for these brain-gut behavior therapies that I'm going to talk about today. So what types of problems do I see as a gastropsychologist? Just to kind of give people a sense of what types of problems might come about from the GI doctor referrals. So we have people, obviously, I'm going to talk today a lot about irritable bowel syndrome, but we also see a fair amount of anxiety and avoidance behaviors related to bowel movements or related to other kinds of digestive problems, such as hiccups and belching and nausea and vomiting, acid reflux. We see Crohn's disease and ulcerative colitis and all of the complexities that go along with that. And we also help with problems such as fecal incontinence or chronic constipation. So I'm going to talk a lot about IBS today, but I wanted to briefly just mention that there's a wide range of types of patients that we see in the gastroenterology setting. Key talking points for today. One is, as was earlier mentioned, irritable bowel syndrome is a very common disorder of gut-brain interaction. We actually used to think of these as psychosomatic conditions. That's how I got started back in Albany 25 years ago. I trained with Ed Blanchard, and he had me do sort of a meditation study with irritable bowel syndrome, with the idea that IBS at the time we thought was a physical manifestation of worry. And what we're going to see as I present today is that really that thinking has changed, moved away from that psychosomatic hypothesis, and really have focused more on the pathophysiology being multifactorial, including neurological, microbiome, and a lot of other factors that drive this symptom dysregulation. We know that our behavioral interventions, most of which you'll be familiar with as psychologists and psychiatrists, have been adapted to address the GI brain-gut connection. And so we're really proud to be able to say that most of our treatments are actually improving GI symptoms, in this case, abdominal pain and altered bowel habits, particularly cognitive behavior therapy and gut-directed hypnotherapy really have been well integrated into gastroenterology practices, which is very exciting. So if we talk about irritable bowel syndrome, which is our bread and butter, most common gastropsych situation, you'll see that the worldwide, it really doesn't discriminate around the world. It's very common. It's a very common condition, particularly in the United States and most of Asia. And we really want to make sure that we're both identifying these conditions because they can be so complex and burdensome for patients. For those of you who may not be as familiar, we do have criteria for our many disorders of gut-brain interaction. There's actually 32 Rome 4 criteria. For 32 different disorders. Actually, I just got back from Rome because we are about to start on our Rome 5, which is sort of like the DSM of disorders of gut-brain interaction. And there's probably going to be 36 or 37 disorders. But irritable bowel syndrome falls under the bowel disorder category. And as you can see, it also includes things like constipation, diarrhea, bloating, distension, and opioid-induced constipation. And then these are things that you're all seeing in your practice, I'm sure. But we do have criteria for what is irritable bowel syndrome. And this is important for patients to really build that disease acceptance and to build the rationale for engaging in a brain-gut behavior therapy. So just briefly, the main things to point out is that IBS is really considered a pain disorder, right? So you cannot technically meet criteria for irritable bowel syndrome if you do not have abdominal pain and discomfort. Now, that pain and discomfort is associated usually with a bowel movement, and that's why we call it irritable bowel syndrome, right? You may see patients who come in with constipation chronically. They may come in with diarrhea. They may come in with bloating. Those are symptoms. Those do not necessarily equate to irritable bowel syndrome. So I just want to really make that case because when we're talking to patients about things about, them not believing what they have, a lot of times doctors will imply that, I can't find anything wrong, so therefore you must have IBS, right? But what we really try to demystify for our patients is that this is a syndrome. We do know what you have. You have a disorder of gut-brain interaction. You have irritable bowel syndrome, which is a real syndrome that means you have abdominal pain and it's associated with alterations in your bowel habits. And, it's always a fun time in the gastroenterology labs where we make, cakes and T-shirts with our favorite Bristol stool form scale here on the left. But it really helps our patients be able to tell us, yes, I have pain, yes, I have cramping, and my bowel habits look like this. Okay. And so we talk about type 1 through type 7, and then that really helps us subtype our patients further. So we have IBS, and then if you have pain with altered bowel movements that are constipation more than 25% of the time, we say you have IBS constipation. If you have your pain associated with bowel movements is 25% diarrhea or loose stool, then we call it IBS diarrhea. And it does make a difference for medical treatment to know sort of which subtype somebody has. There are people who alternate. There are people who switch over time. So you might start out with IBS-D and kind of over time end up with IBS-C. But the good news about our brain-gut behavior therapies is that they really are subtype agnostic because we're targeting more of that pain and dysregulation between the brain and the gut. A former student of mine did this study where they looked at what patients would be willing to trade off for a month of pain relief in their IBS. And you can see here that people were willing to give up the internet, their phones, sex, caffeine, and alcohol for 1 month of pain relief. So again, this can be really burdensome to patients and really quite disabling. Not only is it the pain really burdensome that they're willing to give up for, but when asked about, would you like to try a medication that had a sudden risk of death associated with it, to give up the unpredictability of your diarrhea or your constipation, you can see here that, again, the unpredictability of bowel habits really drove patients' quality of life in this other study regarding their view of medications. One of the problems that we face in gastroenterology, on the gastroenterology side, is that medical management is really still very symptom driven, and we don't do a very good job, as we do in any real field, of managing pain. And so most of the treatments that we have include symptoms such things for constipation, like laxatives or antidiarrheals. And, we can get a little more fancy with some of that if depending on the severity. But again, there's very little that can be done from the pain perspective. And certainly the chronic centrally mediated pain that we deal with. And one of the nice things about gastroenterology and the disorders of gut-brain interaction world is that at this point, GI behavioral interventions are part of the treatment algorithm. This is the 2022 guidelines, and I put it up here to just show you that not only at the beginning are we including in the algorithm patient-provider relationship, education and reassurance, lifestyle modifications, including stress reduction and diet. At the end, we're also talking about augmentation of medical treatments that are focused on symptoms to include central neuromodulators, tricyclic antidepressants, SSRIs, SNRIs, as well as brain-gut behavior therapy. So that is now very easier to talk to a patient about these interventions when they're included in the treatment algorithm, right? We often see in our gastro conferences, that people talking about integrated care as the standard of care, and that really comes from sufficient evidence to show that when you have these coordinated programs with gastroenterologists, dietitians, and psychologists, that the outcomes really are much better. This was a study out of Australia where they randomized patients to either non-multidisciplinary care, just standard care with their GI doctor, to a multidisciplinary care team, and tracked them over a year's time to look at their improvement in their bowel symptoms. And this was in IBS. And what you can see is that there was significant improvement in both the global improvement scale, which is one of our standard outcome measures, as well as symptom severity. So why is this all the case? Why am I sort of talking about what the medical side of IBS is? Well, really, the brain-gut axis is at the heart of the psychogastroenterology field. And I just wanted to kind of go through sort of the pathophysiology a little bit from the psychologist perspective to kind of help us think through for the rest of this talk. So, we all know that the brain and central nervous system are connected to the body. And the gut itself has its own immune system, enteric nervous system, and is very highly connected. In fact, it's hardwired. It's one of the first things that happens after brain development in utero. So we really can never disentangle the gut and the brain connection, but there's a lot of ways that things can go wrong. Now, we know that in our from a lot of our neuroscience colleagues that there is evidence that patients living with irritable bowel syndrome do indeed have altered brain circuitry that affects not just the sensation of signals rising from the gut, but also the ability to downregulate the pain signals once they are in the brain. And so that has really kind of helped us be able to talk to patients about these brain gut behavior therapies by being able to say, we actually know what's happening in the brain when you are experiencing symptoms. Now, there are several factors that are believed to cause that problem, that altered brain circuitry and sensory and emotional processing. So this is sort of where our biopsychosocial model comes in. So first, we have what we consider our risk factors, and I'm going to talk about a couple of those in a minute. We can talk about our influencers, and those might be the psychological comorbidities. And then what we really target in our brain gut behavior therapies is what we call our symptom drivers. These are the things that patients might do in response to symptoms: fear conditioning, catastrophizing, hypervigilance, attentional bias. And that's where we're really kind of focusing on. Now, it's not to say that there's nothing wrong in the gut or the enteric nervous system as well. We know that our IBS patients have disrupted gut motility and sensation. We know that there is alterations in the HPA axis. We know that infection can sometimes trigger the onset of irritable bowel syndrome. We also see a lot of overlap with our Crohn's disease and ulcerative colitis patients who will have ongoing inflammation. They'll finally kind of recover, get back into a quiescent UC state, but continue to have symptoms afterwards due to that post-inflammatory visceral hypersensitivity. So how does this all kind of work, and how do we really try to measure and think about our interventions, both medical and psychological, is really by targeting that brain-gut dysregulation that happens through the HPA axis, happens through our vagus nerve or autonomic nervous system. So on the gut side, we talk about visceral hypersensitivity. That is the continued sensation of inflammation or injury after it has technically healed. And we also talk on the psych side about visceral anxiety, which may or may not be related to something going on in the gut, but is driving the interpretation of symptoms as dangerous or threatening or fearful. And at the intersection of these, both brain and gut, is what we are now calling brain-gut behavior therapies, which we coined in 2021 as a way to sort of destigmatize these interventions. We used to call them psychotherapy, brain-gut psychotherapies, and that type of thing, but we're really trying to increase access and integration. Now, I told you I mentioned a little bit about risk factors. We do see a fair amount of childhood adversity amongst our adult patients with IBS. This is a very old study. You probably have seen this for in other chronic conditions, but we do know that about IBS patients are twice as likely to have had adverse life experiences, that up to 76% of them have had at least one of these adverse childhood experiences. And the more experiences that somebody's had, the more likely they are to have IBS. So again, this is not news to the psychology crowd, but it is something that we often ask about and think about and talk about with our patients as, sort of how abuse history may inform the way that they perceive symptoms in the GI tract. We also know when we talk about our influencers here, we know that depression and anxiety, particularly generalized anxiety, as well as somatic symptom disorders, do present in up to 40% of people living with IBS. And this is from a worldwide prevalence study in 2021 that really kind of showed that the more regions of the GI tract that were bothered by the condition, the more psychological distress somebody had. And so I think this is also really helpful to tell patients that you're getting your depression and your anxiety from the severity or accumulation of your symptoms. So what I mean by that is you could have irritable bowel syndrome, but you could also have one of those other disorders, right? You could have dyspepsia, early satiety and fullness. You could have belching. You could have problems with your pelvic floor and defecating. There's a lot of different areas of the GI tract that could be affected by this brain-gut dysregulation. And the more that happens, we're seeing the more there's also psychological involvement. And again, we know that the microbiome is driving depression and anxiety just as much as it's driving IBS and other GI conditions. So it makes sense that this overlap is happening. I'm not going to actually talk too much today about managing comorbidity in the IBS because I think you all know how to do that pretty well. I really want to talk more about the GI specific, but if you are interested, we did just publish a review article in Nature on how to manage mental health comorbidity in patients with IBS. Okay, so the most important pathophysiology from a psychology perspective is these altered symptom drivers. And these really form the basis of our cognitive interventions and our behavioral interventions. There's really sort of two domains that we really focus on that have the most evidence. One is fear conditioning and negative expectancy. So that what we call probability overestimation, or that sort of assumption that threat is about to happen, right? So a lot of our patients will kind of sit down at the table to eat a meal and have this fear that they're going to have pain with eating, right? And so that negative expectancy almost makes it a self-fulfilling prophecy. So maybe they engage in avoidance behaviors. I don't eat all day and I wait until I get home from work to eat because I don't want to have a problem while I'm at work. We see a lot of safety behaviors, wearing protective underwear or diapers, if you will, especially if you're going to ride on the subway train here in New York City. So there's a lot of sort of that fear conditioning and expectation. There's also a fair amount of maladaptive cognitive processing, and it makes sense, right? Once you've had something bad happen, it's really hard to argue that it doesn't happen again. So let's say you've had a bout with fecal incontinence. It makes sense that you might start to worry every time you have the urge to go to the bathroom that you might have an accident. So one of the other areas that we focus on is sort of these catastrophizing of either pain or other worst case scenarios, or overestimating the probability of them happening, right? So what are the chances? How many times do you ride the subway and not have a problem versus that one time you do have a problem going to the bathroom? And then also decatastrophizing that. So just to sort of review the pathophysiology here, we do know from our brain imaging colleagues, particularly out of the UCLA, has done a ton of work in this area, that there really are sort of overactive affective circuits and impaired cognitive circuits in our IBS patients, and that even normal sensations that you or I, who don't have IBS, let's say, might feel in our guts are sensed at the brain level at a much more amplified level. So we're really kind of seeing this amplified sensation of normal physiological sensations in the GI tract. So hunger or fullness, the need to have a bowel movement can be felt as painful to somebody with a functional GI disorder, whereas somebody without this problem may not even notice or notice and be able to distract themselves. So moving into the brain gut axis as the mechanistic basis, this is how we sort of provide that rationale to our patients, right? We make sure that they really have a solid understanding of the pathophysiology, that we've explained the brain gut connection that really well, that we have gotten some kind of buy-in that this is a scientific approach that targets the underlying pathophysiology of the syndrome, and that can make a really big difference in the uptake. And we spend a lot of time in our gastropsych community educating our physician colleagues in how to talk to patients in a way that sets them up for that brain gut behavior therapy. We also spend a fair amount of time talking to them about how to not wait until a patient is in severe distress or has severe disability before bringing these types of interventions up, because we don't want our patients to think that they're only getting these interventions because they've failed everything else. If we set up the brain gut connection right with our patients, then it makes a ton of sense that you might want to do a brain gut behavior therapy at some point in your intervention. So what are these brain gut behavior therapies, right? So we've kind of defined them. We say that they're clinician administered. And the reason that I actually bolded that and pointed it out here is that, there has been an advent, as there has been in psychology field, of digital tools for irritable bowel syndrome. So there are gut-directed hypnotherapy apps, there are cognitive behavior therapy apps that are certainly somewhat evidence-based, preferred by certain patients. But what we've really tried to do is explain to our physician colleagues that to really be receiving a therapy, this is something that would be clinician administered. And the reason for that is that it's personalized. Everyone's kind of coming in with with the diagnosis of irritable bowel syndrome, but the things that started off, maintain, and perpetuate it are very different, and the behavior therapist can really personalize it and be very effective. Our interventions follow along with the cognitive behavioral framework, meaning they're self-regulation based, teaching patients how to manage symptoms in real time, as well as set up a lifestyle that reduces their overall level of arousal and attention to GI symptoms. Most of our patients are seen under 6 months' time in the IBD center at Mount Sinai, for example. Most of our patients are seen in under 6 sessions. The focus is really on GI symptoms and quality of life. And this is part of the problem, the disconnect between psychologists and the gastroenterology world, because many of our randomized controlled trials for IBS, for example, don't even really look at improvement in things like depression and anxiety or somatization, because they're so focused on that endpoint of reduction in abdominal pain and increased satisfaction with bowel movements. And so it's really hard for us to say what exactly is it that we're working on other than GI specific anxiety. But it's likely that our interventions are doing more than just working on the GI symptoms and quality of life. That said, there are some studies that have shown that patients with significant mental health comorbidities, generalized anxiety disorder, obsessive compulsive disorder, major depression, actually don't respond as well to these brain gut behavior therapies for a lot of the same reasons, right? Because they really need to be prioritizing the mental health component of this. The other issue with our randomized controlled trials, which I will talk about in a second, is that none of them have really been done as standalone. So brain gut behavior therapies haven't really been tested as a standalone therapy for IBS. There's sort of a sentiment in the field that you might be able to give them to milder cases upfront as a single standalone therapy, but that hasn't actually been tested. So if there's anyone out there that would like to do a dissertation or a grant on that, that would be a great area to kind of look at it as a standalone intervention. But most of what we're talking about when we talk about our outcomes is the assumption that people are receiving these interventions conjointly with changes in their diet or with symptom-based medication. This is a great new paper that just came out looking at our existing brain gut behavior therapies and their effect sizes when compared to controls. And this came out of Sweden. Brian Jotzin is a senior psychogastro person. What you can really see here nicely that, first of all, most of our interventions work. So that's a good sign that anything you do behaviorally is going to hopefully improve irritable bowel syndrome. But that there is some favor to cognitive behavior therapy, particularly what's looking increasingly to be exposure-based psychotherapy. And that goes back to that fear conditioning and avoidance behavior that we see in our IBS patients, but also some gut-directed hypnotherapy is also really kind of growing in popularity, and effect is a little more heterogeneous in terms of its effect. That's because there's several different protocols out there. There's several different theoretical frameworks around the application of hypnosis. It's a lot less tight than a CBT model might be. But again, just to sort of show you the growth in the field here, there's over 30 randomized controlled trials for CBT. There's probably 20 for gut-directed hypnosis. So we're really starting to be able to build that confidence that these interventions indeed are effective. When we look at what are the specific mediators and moderators, so why would you give somebody CBT or hypnosis in this area? We also are able to start now, as our research improves, to be able to look at specific techniques that you might see in CBT or you might see in hypnosis that could explain what they're targeting. And that's why I spent so much time earlier on the pathophysiology, because you can see that there are some conditioned physiological alterations. So habit reversal, common example of this is in our belching patients, right? Where they feel the urge to belch, they feel better, it reinforces that behavior. Then they start to check to see if they have to belch, and it becomes a habit. Even though we all belch, sometimes patients need that extra help with habit reversal. Another example is every time you feel the need to go to the bathroom, you go and sit on the toilet for 20 minutes. And instead of what we joke with our patients is letting it brew for a little bit before sitting on the toilet as a way to build control and reduce that habit of going every time you think you might have to. Obviously, there's a lot of cognitive techniques. I'm going to talk about those in a second. Exposure-based techniques, same concept. We do a lot of behavioral experimentation. There have been some studies on exposure. And then general, almost all of our interventions, in one of the main mediators and moderators of our brain gut behavior therapies is modification of arousal. So whether that is diaphragmatic breathing, whether that is progressive muscle relaxation, guided imagery, any of those things, most of our interventions do include some form of modification of arousal. And again, that's really related to that fight or flight response that patients have when they are having GI symptoms. So for example, in bowel urgency, which is probably one of the most common things that we see, right? Patients will say, oh, I was at Gristedes at the grocery store. All of a sudden I had to go to the bathroom. I left all my frozen goods in the cart and ran home. Right? What could I have done differently there? And we will often teach sort of this ability to earlier detection of that arousal, right? That sort of teaching of diaphragmatic breathing. We actually have our patients breathe in 4 seconds in, 6 seconds exhale as a way to turn on that parasympathetic nervous response, which will slow down their motility, decrease the likelihood that they're going to need to use the bathroom, and they can sort of continue with their grocery shopping. So that might be another sort of modification of arousal strategy that can work sort of in the moment. What we try to talk to our patients about as why brain gut behavior therapies work is we give this analogy of the fire alarm, right? And we've all been in the hospital. I was just there on Tuesday and the fire alarm kept going off during my session. Right. We know if you were really concerned that that was an actual fire, right, you would just run out of your room, down the stairs, out to the front, and you would leave your coat. You would not take your cell phone. You wouldn't be looking for your friend to walk down the stairs with. You would just leave the building. You might even jump, who knows? If you knew it was a drill, right, you would try to make yourself comfortable. You'd say, this is annoying. This is inconvenient. If I'm going to go have to stand outside and wait for the fire, people to come and clear the building, I'm going to grab my coat, my coffee. I'm going to find my friend. Maybe I'll even bring a book with me and just sort of wait it out. That's all we're trying to do. We're not trying to take away from the patient having that pain and saying it's in your head or that urgency isn't real. We're just saying how you interpret it is really going to be contingent on how you respond to it. And that is obviously the premise of CBT, but also just a way that we're able to talk to our GI patients who may not necessarily be making that leap, right? They're not coming in for psychological services per se. We're able to kind of talk to them in this other way about our moderators. So just to give you an example of GI focused a CBT. Let's say we have a patient with constipation. They might be complaining of fullness and bloating and pain. And that may be related to all of those things that we just talked about, brain gut dysregulation. Maybe they have slower motility. Some people have longer colons than others, redundant colons. So it just takes longer for things to move through their system. Some people don't get enough fiber. Sometimes people are depressed and they're slowed down in general, and constipation can kind of play a role. And so for a variety of reasons, there's that brain gut dysregulation, constipation symptoms. But then patients start to develop a mindset around their constipation that makes them avoid or have an impact on their quality of life. So these would be negative thoughts. If I don't have my bowel movement today, my day is ruined, right? This sort of fixation on, I have to go to the bathroom, I have to empty out. I'm bloated, I'm full, I have pain. And to me, the only way to relieve that is to have a bowel movement. So maybe I get up, 3 hours early in the morning so that I can have a bowel movement before I go to work. Maybe I'm finagling my body into weird positions so that I can trigger a bowel movement. Maybe I just don't eat so that I don't make myself as much full. But all these sort of behaviors and emotions that kind of come along with those negative thoughts can really impact quality of life. It can impact social relationships, right? It's really hard to explain to somebody that you can't come to their house because you didn't have your bowel movement for that day, or you're afraid that you're going to have a bowel movement at somebody's house. So all of these things really become isolating and reinforcing. So, the targets of our interventions tend to, from a CBT perspective, our targets are really kind of focusing on both those negative thoughts. So reframing those thoughts that your day might not be ruined if you don't have a bowel movement. And also that behavioral modification, which is trying to get people to not spend so much time on the toilet. Or it might involve exposing them to going to the bathroom at a Starbucks instead of only at home. Here's an example that is pretty common, actually. This is a young woman. She's going to her boyfriend's family lake house for the holiday. She's having these thoughts: I'll take forever in the bathroom and everyone's going to notice there's only one bathroom. Then after I go, the bathroom's going to smell bad. Everyone's going to think I'm gross. It'll be humiliating. And then I'll be so bloated, there's no way I can wear a swimsuit. So those are just sort of automatic thoughts. They seem very normal, right? We all kind of have those views around bowel, unfortunately. Nobody wants to be the one in the bathroom. That's why when you go to the bathroom and public places, there's always a little spray bottle there. So these are all sort of normal thoughts, but they're not helpful thoughts, right? And so, she came up with some strategies for coping, which would be to sort of change up the time she goes to the bathroom, trying to have her bowel movement in the middle of the night when no one else is around. Maybe not wearing a swimsuit or avoid wearing a swimsuit by not going to the pool or to the lake, that type of thing. So if we were to reframe this, we might ask, how long do you really spend in the bathroom, right? Because a lot of times patients will overestimate the length of time it takes them to go to have a bowel movement. By the way, the average bowel movement, if you're going normally with that Bristol 4 or 5, takes about 12 seconds. Okay, so any additional time somebody's on the toilet is really their own sort of thinking about it or trying to go or straining. How, realistically, would people understand if you had a little problem and you were in the bathroom for a length of time and they had to wait a minute to go in? Would you die of embarrassment? Similarly, and again, this is very familiar to all of you with anxiety patients, right? So, but we might say, let's try having a bowel movement when you have the urge, right? That's the most likely time you're going to be able to actually go, usually like within 30 minutes of waking up or 30 minutes of a meal. Go when you have an urge. That'll give yourself the best chance of going, not spending so much time, not being uncomfortable, and really kind of focusing on enjoying yourself. We might also do behavioral experiments with our patients. So we might say, what would happen if you don't go to the bathroom this morning and you're saying your day is ruined? We might say, if they're really having a hard time cognitively with that concept, we might say, you know what, your goal is to literally get out of I have somebody I'm working with right now. Your job is to get out of the house without going to the bathroom. Because he was finding that he had to get his kid to the bus every morning. And in order to do that, even though it was a 5-minute walk to the bus, he felt like he had to empty out before he could go. Because what if he had to go to the bathroom on the way to the bus, right? So we really started with this behavioral experiment of, you can wait 10 minutes, the 5-minute walk there and the 5-minute walk back. So leave the house without going and seeing what happens, right? Let's try a behavioral experiment. And the more you kind of do that, the more likely that you'll adopt a new belief, that you have some control over your urges, that your day isn't ruined if you don't go to the bathroom. You might be uncomfortable, you may not approve of that, but it's okay. When we look at some of the largest trials of CBT and largest, most recent, this was one looking at the impact of a telephone delivery versus web delivery, still with clinicians. They were actually nurse clinicians, versus treatment as usual out of the United Kingdom. Almost 600 patients. They actually followed them up now for 2 years with similar results. But again, I just wanted to sort of highlight that the outcomes that we're looking at in our CBT trials are symptom severity, of IBS symptom severity. And so you can see here that the group that got treatment as usual did not really improve much after that 6-month placebo rate. 40%, we have about a 40 to 60% placebo rate in our IBS trials, which does, by the way, make it very hard to run a study against a treatment as usual control group. Most of us now believe that in order to run a randomized control trial in CBT, you would really need something to control for time and attention. But I will point this out anyways. And you see here that 73% in the patients who received the telephone delivered CBT had significant reductions in symptoms at 12 months, and the web did okay as well. The reason I bring this trial up, even though it ran against a treatment as usual and not an attention control group, is that it formed the basis of Mahana, which is a CBT app, standalone, no clinician delivery for IBS. And so many of our GI doctors now are prescribing Mahana. It's FDA cleared to patients, and it was sort of based off of this larger trial. In another trial that looked at whether you could take our standard 60-minute CBT, or I'm sorry, 12-week, 10 sessions CBT model and deliver it sort of faster by offloading a little bit more of the homework on the patient with a self-delivered, manual, but still with therapist contact. Could you also see that? And so in this study, we actually ran our minimal contact, so the 4-session CBT, just all the same skills packaged into less sessions, versus the standard 10-session model that had been historically tested and proven to be effective, versus a time and attention control group. And you can see here that actually the minimal contact patients did better significantly than certainly than the attention control, but even from the standard. And we have reason to believe that both the motivation of the therapist, the high intensity of the sessions actually probably helped the patient get better faster in that real world experience by doing the homework outside of the sessions. There was also a study that I particularly love on looking at interoceptive exposure. So having patients sort of tie their pants tighter, patients eating a little bit of a feared food, all as ways to kind of improve their tolerance of visceral sensations. And so you can see again in this study that interoceptive exposure did better than stress management or attention control. And more recently, this has really been taking off. We're even starting to see some return on investment of exposure-based CBT therapies, both in terms of cost and getting people back into life in the workplace. Obviously, it's hard to get people who are in chronic pain to engage in exposure-based interventions, but it's certainly an area for the future. And then lastly, I just wanted to, so that I can leave plenty of time for questions, I just wanted to mention the second class of brain-gut behavior therapy, which is gut-directed hypnotherapy. So gut-directed hypnotherapy, I always describe it to patients as, if you think of a needle going into your arm for an infusion, right? That is the hypnotic state that we're going to put you in, right? We're going to put you in this dissociative, highly focused, relaxed state. And then if you think of the actual medication that's going in your arm, the dose that we're pushing inside that infusion, that is the gut-directed part. That is the specific suggestions that we're making related to your bowels. And we have several protocols that we can use. And one of the benefits of that is that we're able to have non-psychologist professionals provide the gut-directed hypnotherapy by using these scripted protocols that have been scientifically tested. But something might include, in situations where you might have previously had abdominal pain after eating, now you just feel a warm, comfortable sensation in your stomach, right? And so we're really kind of targeting not just the modification of arousal that would happen in a hypnotic trance, but also very specific suggestions related to what we know about gut-brain dysregulation. And that really forms the basis of it. The patients who do the best with these are the ones that have less of that cognitive, need for cognitive reframing or behavioral avoidance, but really have more of that somatic symptom experience, pain elsewhere. Maybe they have visceral hypersensitivity from a prior infection or inflammatory process. So we're really trying to focus on that, how the brain is perceiving the sensation from the gut into the brain using hypnotherapy. And again, subtype agnostic, as I mentioned before, and we're really where we see the most improvement in patients with IBS is really in those is in the area of abdominal pain, which makes sense. Hypnosis is used for pain management across the board, not just in IBS. So again, just to summarize, IBS is a very common condition. Up to 10 to 15% of people will have IBS at varying degrees. It is a very heterogeneous condition. Everyone's symptom profile is a little bit different, which makes it hard to study. The pathophysiology is multifactorial. I didn't mention today, but there's a lot of work going on in sort of the microbiome, and that's contribution to both mood and anxiety in IBS, as well as GI sensitivity. We know that our behavioral interventions, when they target these gut-brain microbiome dysregulation, can be pretty effective, particularly if you were to pick something that you wanted to try with your patients in your practice. A CBT that's sort of adapted around these GI symptoms, as well as a gut-directed hypnotherapy, are all kind of well integrated. And again, I just wanted to point out some resources if any of you are inspired or want to do more in your gastropsych training. We do offer training, continuing ed credits through the Rome Foundation Gastropsych. You can learn hypnosis, CBT, acceptance and commitment therapy, learn about brain-gut physiology as well. And then there's also some book opportunities. I will stop there.
Wonderful. Thank you so much, Dr. Keefer, for this interesting presentation. I think many people do not know all of this. So we're glad to have you on board. We are in the question and answer period now. So anyone who is interested in asking Dr. Keefer a question can enter it into the Q&A section. If you would like to ask your question out loud, you can raise your hand and we will bring you on after we answer the written questions. So, Dr. Keefer, your first question comes from an anonymous attendee, and it is, can you speak to resources for using these interventions with pediatric populations and their primary caregivers who often perpetuate the maladaptive behaviors related to eating and toileting?
Oh, yeah. Yeah, that's a great question. I didn't talk about pediatrics, but a lot of the same brain gut behavior therapies do work really well for that. And in fact, there's some work out of the University of Washington from Rona Levy and her group where they actually did parental cognitive behavior therapy, which actually reduced the kids' IBS symptoms. So sort of getting to your point, which is that pain solicitation that we often see. How's your stomach ache today? Oh, are you going to be able to eat that? All of those sort of maladaptive behaviors, or you better sit on the toilet until you go. We can't leave the house until you go, right? All of those are definitely parenting behaviors that can directly impact it. The other thing I would say is that in genetic studies, which I didn't get into, they've looked at twin studies of IBS, and actually the likelihood of a twin having it without a parent having IBS is pretty unlikely. So twins don't tend to get them. But if a parent had IBS, the likelihood of their child developing IBS is actually pretty high. And a lot of that is believed to be that behavior, right? That for the same reasons the parent might perpetuate their IBS, might perpetuate it with their child. So there's a lot of social learning in the pediatric population.
That's helpful. Thank you for sharing with that. You have another question, comes from Paul Moglia. Many patients report feeling their anxiety and emotional stress in their gut. Can you speak to how BGBT might be applied to the management of anxiety control?
Yeah, that's a great question. Yeah, I mean, we talk about gut responders. We talk about the normality of people feeling sensations in their gut. Some of the early experimental psych research from like the 1950s involved putting electrodes on people's guts and watching them drive through London traffic and looking at the amount of contractions and dysregulation that would kind of happen under stress. So I think that there is such a huge connection there. And I think if your patients are able to really identify early on that tension or that stress and anxiety in their gut, I think that can really be almost like your early cue detection for eventual like anxiety thoughts, right? I think what you have to be careful about is that they don't further catastrophize those sensations in their gut as something is wrong, right? And so that pairing of like trying to de-pair a gut sensation, because sometimes people will feel anxiety before they have a thought, and vice versa, if that answers. But I think a lot of these anxiety therapies are very similar to what we do in the GI. So I think that they're very compatible.
Okay, thanks for that. You have a question in the chat, comes from Goldie Alfasi. Which of these techniques, if any, work for Crohn's?
That's a great question. Yeah, I could give a whole talk on Crohn's and ulcerative colitis. A lot of it is the same brain gut behavior therapies. So we do a lot of CBT around Crohn's or ulcerative colitis in remission. So when you're in remission, most of these interventions are very similarly effective as they are as if you had IBS. Okay, so in remission, we would do gut-directed hypnotherapy. I actually have a protocol for IBD where we talk about maintaining remission as part of the therapy. So rather than reducing IBS symptoms, we're talking about keeping yourself in remission, identifying things that might cause you to lose your remission status, that type of thing. So hypnosis has been shown in a randomized trial for quiescent IBD. And then obviously CBT. But we would also, I think, where I see a little difference in Crohn's and colitis is in more of the acceptance-based work, right? So we tend to do a little less of the, decatastrophizing of needing to have a bowel movement and more around sort of that acceptance of the diagnosis, the acceptance of the uncertainty of having this chronic condition, and a lot of there's some unique issues that people with Crohn's might experience that the patient with IBS you might not see so much.
That makes sense. Thank you for that. Oh, you have one more question. Alexandra Stratiner asks this. Do you have any specific recommendations for the utilization of these interventions among individuals with autism or resources on this topic that you could recommend, who often have comorbid medical concerns, but in my experience often require modifications to behavioral therapies to help support learning and utilization of skills?
Yeah, that's a great question. So there's a lot of overlap between autism and disorders of gut-brain interaction. And actually, Kara Margulies at NYU is probably one of the prominent researchers in autism and disorders of gut-brain interaction in pediatric cases. So I would definitely look her up, Margolis. But, so a lot of these interventions, we tend to do obviously more behavioral work with autism, around toileting behaviors, around, sensory perception exposure to sort of tolerating sensory feelings in the GI tract and how those are interpreted by the brain, depending on the severity of autism. I think where it's a little harder is in any kind of gut-directed hypnotherapy. I tend to stay away from patients with any sort of significant autism and kind of go more with the behavioral strategies. Although you can do something like progressive muscle relaxation on the toilet to help with tension or toileting behavior. You can certainly set up reinforcers around toileting behavior as well. But with pain, I think you have to be a little bit more behavioral in terms of tolerating pain, and not so much on the cognitive side.
Okay, that's helpful. We have a break in questions. Oh, there's one more. Paul Moglia. Thank you, Dr. Keefer, for a wonderfully informative talk. This was a wonderful way to connect theory and pathophysiology with practical interventions. Thank you.
Thank you. Yeah,
I think that's a nice note to end on, because I think we're just about to wrap up here. I want to again thank Dr. Laurie Keefer for joining us in Psychology Grand Rounds this month. And everyone, come on back and stay tuned for February grand rounds, which will be on February 2nd, and we'll see what else we can learn there. So thanks again, Dr. Keefer, and have a good day.
Yes, thanks for having me.
Okay, bye.